Okay, welcome again to the Epilepsy Podcast. We're really excited today to have Dr. Joseph Neimat. Dr. Neimat was one of my mentors at Vanderbilt and probably the first attending to really teach me about the how interesting epilepsy surgery is, how complicated the mesial temporal anatomy is, and so really get me excited about some of this work that I'm doing now. Rohit, can you give us a formal introduction?
Sure. Today we're happy to have Dr. Joseph Neimat join us. He is the chairman of the Department of Neurological Surgery at University of Louisville. Dr. Neimat came to the University of Louisville from Vanderbilt University, where he held a variety of positions, including associate professor and the director of human neurophysiological research, neurotrauma, epilepsy surgery, and the functional neurosurgery fellowship. Dr. Neimat's current research interests include investigations of the affective and cognitive properties of the basal ganglia. His research also examines the clinical application of neurostimulation in the treatment of disease that is resistant to current therapies. He's the lead or co-author of approximately 90 peer-reviewed articles. He's published abstracts and published textbook chapters. Today, he joins us to talk about the decision making behind epilepsy surgery. Thank you so much for joining us, Dr. Neimat.
Thank you for having me. It's a pleasure to be here.
So, Dr. Neimat, to start us off, for patients with refractory focal epilepsy who are being planned for resective surgery, how do you decide which areas of the brain to remove or disconnect? And can you explain the difference between the terms epileptogenic zone and seizure onset zone?
Sure. Well, let me just start by saying what a pleasure it is to have been invited here. I always enjoy talking about epilepsy. It's especially a pleasure to be speaking with Luke, who I had the pleasure of training some years ago, and who's become a wonderful colleague in epilepsy surgery. And so this is really very enjoyable for me. Yeah, epilepsy surgery has been something that I have really, as my career has gone on, among the things I do, DBS, epilepsy, pain, etc. Epilepsy has become my favorite because over the last decade, I think we really have had such a rapid increase in the techniques that we have to diagnose and treat epilepsy. And so, what had been a relatively simple question, when I started my career, there were sort of two questions. Do we do surgery to put in grids and find a seizure focus, yes or no? And if so, then do we resect or not resect, yes or no? It was a relatively simple calculus that got us through this. Today, we have many, many more techniques to diagnose the epilepsy and to treat it. And so it really has simply just become more fun, more exciting to do this. That's a long-winded preamble, but let me answer your question. In patients who are having continued seizures despite adequate medications and such, we start by asking ourselves the question, okay, where is the seizure coming from? And that, in essence, is the question that you asked: what is the epileptogenic zone? And there has been, there's sometimes confusion between what is the seizure onset zone, what is the epileptogenic zone, what is the lesion if there is a lesion. Um, these things have definitions that are overlapping, but in essence, a single seizure will have a seizure onset zone. An epileptogenic zone is perhaps a broader area that is prone to seizure. And so your treatments in general, as much as possible, we would like to address the epileptogenic zone in its totality and resect that or treat that in a way that prevents a seizure coming not just from one spot, one seizure onset focus zone, but from all potential areas. Um, and so the trick is figuring out what is the extent of that area and can we resect it safely? And then how you answer those questions, is there a single focus? Can we resect it safely? That, I think, really leads you to decide on the therapies that you are going to propose. In general, when we can resect the epileptogenic zone safely, that is, to date, the best and most effective therapy. We have seizure freedom rates that are approaching 70% in many of those cases. Whereas with the best neuromodulation therapies to date, although they're improving all the time, we are only able to reduce seizures. Give me 1 second. I'm just going to close the door here so that it's quieter. Very sorry. Okay. So where did I leave off? So, in general, we would prefer to, at this time, to resect a seizure focus and an epileptogenic zone if that's possible. When it's not possible because it is an eloquent area or because those foci are multiple, then we look to sort of, more palliative methods, neuromodulation, et cetera.
So let me interrupt you there because we'll get, it's a good segue into this next question that I want to address. So you brought up multifocal epilepsy, you brought up non-lesional epilepsy, and then there's epilepsy that comes from actually eloquent cortex. And I was wondering if you could talk about some of the limitations we have as surgeons in treating epilepsy that comes from eloquent cortex.
Hmm.
And then maybe in that answer, you can also address a little bit fMRI and WADA testing, or what's sometimes called intracarotid amibarbital testing. What is the role of those studies in understanding functionality of the brain in eloquent cortex epilepsy?
Yeah. I think today we've had a relatively restrictive definition of what is eloquent cortex. We have talked about essentially eloquent cortex being a primary motor area where resection of that region may produce a permanent motor deficit, or a primary language area, Wernicke's area, Broca's area, et cetera, where resecting that area will produce a substantial language deficit. Certainly there are multiple other areas that are functional, eloquent in the sense that they are producing some function that may be identified and missed, when the resection is done. And so I think it's also important to sort of think more broadly about what is eloquent, what is meaningful. Can we restrict our resections? And we'll get into this when we talk about laser ablation. Can we do things to limit our resection to maximize subsequent function? But I think we can all agree that we certainly don't want to resect in areas that are going to produce a permanent significant deficit in motor or language function. And so those are the things that we think about sort of principally in identifying, where is the seizure focus and does that overlap with these eloquent areas? In identifying those areas, there are a variety of techniques that we can use. Before surgery, we can use fMRI, which will often tell us, what areas are contributing or involved in these functions. Those studies, just because of the nature in which they are done, it shows areas that are correlated with those functions. It is not necessarily showing areas that are necessary for eloquent.
Right. And I'll tell you, Dr. Neimat, just to throw in the pediatric population, we still struggle a lot of times with getting useful information, especially
Sure.
with young kids who have limited speech, limited ability to really follow very complex commands and paradigms. It's functional MRI can be a challenge for us.
Yeah, no, so there certainly are limitations to that. It tends to be, I think, a relatively sensitive test, but not a very specific test. And I think that's an important differentiator in talking about epilepsy evaluations. The other option is the WADA test or amibarbital test. These are nice tests in the sense that they tend to be more specific. They tend to be relatively conclusive. If you see significant memory disruption with injection on the left or right side, you can I think at least feel comfortable that, well, perhaps we should not do that resection and we should look toward more palliative measures. It's not to say that there isn't could we be ruling out some patients that might otherwise have surgery? Perhaps, but I think in general that is a test that when it's used can be very helpful.
Dr. Neimat, in years, there's been an increased focus on epileptogenic networks as opposed to a single focus. How has this changed your approach?
Yeah, that's a good question. I think it's interesting how sort of the techniques and the focus or theory surrounding epilepsy. I think these things go hand in hand. As we have, I think, as a field shifted towards stereo EEG, we find ourselves most frequently not just putting grids on the surface and detecting seizures in one region or area, but having electrodes that span multiple areas. And as a result, what we frequently see is that seizures are active in multiple areas and they start in one location and spread very quickly to another, or perhaps two areas which are not strictly adjacent to each other are both meaningfully involved. I see the identification of those networks is simply an expansion of what we are describing as the epileptogenic zone. And so when you see that, it may be meaningful to treat both areas. It may suggest that a modulatory therapy may be more effective because you may have difficulty, if these areas are multiple, we may not have a difficulty, resecting each of the nodes of that epileptogenic network. But I think understanding that is important as we this is also helping us, I think, understand, there have always been a number of patients who fail epilepsy surgery. Despite our best efforts, 30% or more may not be seizure-free. And why is that? It's perhaps because our identification of a small seizure focus in one area is not the whole story, is that there are regions that are involved beyond that small area.
So speaking of patients who fail epilepsy surgery, are patients who have normal brain MRIs, or we call them sometimes MRI negative patients, along with our multifocal epilepsy patients, like our tuberous sclerosis population. I think the MRI negative population continues to be one of the most challenging for us as surgeons. We know that often focal surgery can lead to a cure or a resolution of seizures, but it often requires a lot of other work in terms of diagnostic work. And a lot of times that might mean getting a PET scan, getting a MEG scan, getting an ictal SPECT to better understand areas of abnormality. Can you give us, again, for the surgeon who's looking for focality, can you give us a little bit of a sense of when at your institution you're getting these studies, when you think they're most appropriate? Do you get them all the time? Do you get them in certain situations? Can you talk a little bit about these studies?
Yeah, certainly. So I think we do, as sort of a standard protocol, get high resolution MRI and PET scans, intraictal PET scans on
pretty much everyone with
pretty much
epilepsy, drug
every patient.
resistance.
And in my mind, I think of the PET scan as a somewhat more sensitive but less specific imaging study that, it'll tell me if there is a region of hypometabolism that could contain a sort of occult lesion, but may not be present on the MRI, which is a little bit more specific in those cases. But I have found that useful in some patients where all of the other findings line up. We have a patient who has a semiology that is suggestive of a right mesial temporal seizure focus. We have the MRI is negative, but the EEG is convincing for a seizure in that location. And so if you have those two things and you match that with the PET scan, that sometimes is enough. You add up the pieces and you say, okay, this is suggestive enough that I feel comfortable moving forward. So that's the first step. In cases where that's not the case, that's usually when we start to employ techniques like ictal SPECT and MEG. And in both of those cases, I think I'm utilizing them when I have a patient, where we really have a lot of uncertainty about where the seizure focus is. The semiology is somewhat nonspecific. The EEG may show seizures that, again, are either nonspecific or perhaps multiple seizure types, and we're not sure which of these are predominant. In those cases, I think you can get important information from ictal SPECT and MEG, typically not enough to plan a resection, but perhaps enough to guide stereo EEG or grid placement. So you say, gee, based on these additional studies, I have a growing suspicion that we're looking at the left frontal lobe or the right frontal lobe or these
Right.
sides. That's how I sort of think of those as a kind of a pathfinder, but not a conclusive study that I would hang a resection
Yeah,
on.
and again, I'll just we do something quite similar. We're getting now 3T MRI on pretty much everybody. We're getting PET on pretty much everyone. But we do have a MEG here in New Jersey. So we're getting MEGs typically if there continues to be some uncertainty. Ictal SPECT is obviously tricky. Not everybody is a good candidate for ictal SPECT based on the length of their seizure. And so there are some other considerations there, but I certainly think they're important studies. And I'll tell you, I've noticed, at least in a lot of the epilepsy conferences that we have, that one of the things we suffer from is a problem of under imaging. I always say, I think these are free studies. We can get them on anyone. They're non-invasive. And if you don't look, you're not going to find something. But if you look, you just might. And so I think they're helpful in that regard. Tell us a little bit about semiology, Dr. Neimat, and how your team, your conference, will use semiology either in your SEEG planning or just in general as part of another piece of this puzzle.
Yeah, I think it can be actually a fantastic, again, another pathfinder that sort of helps you identify areas where you have a strong suspicion. I think we all ask the question of patients, okay, do you have an aura? What does that aura feel like? What is the first thing that you notice in a seizure? Is there a second thing? Does it spread in some way that is comprehensible? Those things I think can be really important clues to where the seizure focus is. They can also be misleading. You can have, I've had patients with sort of very, very prominent motor seizures, hypermotor seizures that would occur in the middle of the night. And we thought, well, this is certainly going to be a frontal seizure focus, and found after stereo EEG that it was very clearly temporal,
Yeah.
and responded to a temporal lobectomy. I think it can fool you, but I think especially an experienced neurologist or experienced neurosurgeon who has seen a lot of these seizures and begins to identify them. The master in my mind, so I worked for years at Vanderbilt with Basal who's a wonderfully experienced epileptologist, and he just, he had identified several different, semiologies that could be associated with different kinds of seizure, and was just the master of recognizing them very early in the video. And I think that's always very helpful to have someone.
You gave me a great idea of another guest we should have, because I'd love to have Dr. Khalil on. Great
He
guy.
he
Really
would be
smart
excellent. Yeah.
epileptologist.
He's someone who really does know a lot
Yeah.
about this and cares quite a lot about his patients.
Dr. Neimat, we've been talking a lot about focal epilepsy, but there are also surgical options for patients with generalized epilepsy or a mix of seizure types. When might you offer surgery to a patient with drug-resistant generalized epilepsy?
Yeah, I think, I think this is an area in epilepsy surgery that is changing very rapidly. Luke, you were going to say something.
Yeah, I just want to clarify here. I think, we're interested about maybe the Lennox-Gastaut population, talking more about if we're not doing a focal resection, sort of calisotomy, VNS, neurostimulation, so some of these treatments that might be appropriate for some of the generalized epilepsies.
Yeah.
Sorry, I just wanted to clarify that.
No, that's great. I mean, I think it is different in different. The different therapies can be used somewhat differently. So vagal nerve stimulation, I think, is a treatment that makes a substantial contribution to patients, and can be done, relatively easily with a low rate of complications, and is applicable to essentially all types of epilepsy. So I view that as essentially another type of medication, an electrical medication that you might offer pretty much any patient with unresponsive seizures. This is an opportunity to reduce the seizure frequency, perhaps reduce the seizure severity, without a large invasive intracranial procedure. And so that is something that I think can be used in many patients. Beyond that, I think you have a variety of options. So I think that the LAMIC DBS is one that has been now approved for several years and is seeing some value in the treatment, maybe primarily of patients with temporal seizures, although it's been done in patients with extratemporal epilepsy. RNS.
And I think they're doing a trial now, Dr. Neimat, for idiopathic generalized epilepsy for thalamic stimulation. So
RNS.
I think it's still an investigation, but they're looking at it.
So responsive stimulation, was initially used primarily in patients with unresectable seizure foci. So where you could identify one or two foci, perhaps they were bitemporal, perhaps they were in eloquent cortex, or you just weren't certain. And so you would put the electrodes essentially in your suspected seizure focus. But increasingly now, there have been a number of small case series and case reports, including one that we've just had accepted for publication, where stimulation in the thalamus, either central-median thalamus, pulvinar, or perhaps anterior nucleus, can also be helpful in reducing seizure frequency. And so I think that's a very interesting therapy. It has the additional advantage that you are seeing, presuming that you have targeted some portion of the network, that the thalamic relay is part of the network that is involved in the patient's seizures. You get a real-time read, not a real-time, but you get an active readout of how many seizures the patient is having, which is often difficult in patients with generalized seizures or multifocal seizures. And so I think that is actually a very meaningful therapy, and it will be interesting to see what that study, the Nautilus study, demonstrates.
Yeah, the role of the thalamus in epilepsy has been an interesting development in this last several years. There's obviously been a lot of talk and research about it. We in our conference even discuss sometimes considering SEEG electrodes in the thalamus to help us with placement of when we think they're ultimately going to get thalamic RNS or DBS to help with placement of those leads. But it's obviously still we're still learning when that's appropriate. You gave a great grand rounds that I saw about laser ablation, minimally invasive epilepsy surgery, using curved trajectories. Obviously, one of the major structures that we're ablating is the hippocampus, and that's a curved structure. Tell us a little bit about some of what you've pioneered and sort of thought about and done some research in this area.
Sure. So I very much like the idea of laser ablation for epilepsy. When I did my first case, I remember thinking, gee, this is a substantial improvement on the way that we've been doing this generally. When you think in patients for whom you want to do a focal hippocampal resection, it really is, I think, a very well-targeted, well-designed technique. It does have some limitations, and as you mentioned, one of them is that the structures that you would like to ablate are not linear. They don't fall nicely in many patients. They don't fall nicely into a linear trajectory, but actually are sort of a curved, especially if you have an amygdala that is sort of high sitting over the head of the hippocampus, you may find yourself having some difficulty getting the body and head of the hippocampus as well as that structure. At a lot of centers, they have started to adopt two trajectory techniques where they do sort of one down the body of the hippocampus and one sort of getting the head of the hippocampus and the amygdala. That is a reasonable strategy, but it would really be nice if there were a curved probe that you could use. And so this came about several years ago when I was at Vanderbilt. I was having a conversation with a friend who was an engineer, and he was looking for an opportunity to sort of get involved in sort of surgical interventions. We originally thought we would pioneer something for a completely different disease. And then he was sitting in my OR one day and saw one of these other cases. And I said, well, I have an epilepsy case coming up next. Would you like to just stick around? And he said, yeah, sure, I'll stick around. And that's sort of when we sort of came up with the idea, gee, this would be nicely applicable. He was using a combination of curved needles that can be steered. They're made of nitinol, and they sort of expand and adopt their curved shape as they enter brain tissue or enter the field, and pneumatic robots that are sort of driven by inflating and deflating different bellows within the plastic. And that combination is a nice solution for a MRI, an intra-MRI technique that would steer needles through any target of pretty much any shape. So we began to explore that first with just modeling and looking at different curved trajectories and whether they could successfully sort of approximate the spine of the hippocampus and amygdala, and then building prototypes, which is sort of the state that it's currently in. So we now have a robotic prototype that we call the Merlin robot, which can essentially enter through the foramen ovale, and because that is very close to the head of the hippocampus, can steer its way through the hippocampus and achieve an ablation. And so we've done that now in models, and we're starting to do it in cadavers, and perhaps we'll have this ready for human application sometime in the next several years.
Very cool, very exciting. It's a nice story, and it, a lot of this innovation seems to be by happenstance, but I think it's not just that. It's somebody who's carefully observing what they're seeing and always thinking about ways to make it better. So that's kudos to you guys. That sounds like a really exciting lead that you're on there.
Thank you.
You wrote a great paper recently. You were co-author in a paper on robotic applications in neurosurgery. Maybe you could tell our listeners a little bit about where you think robots could have an application. Again, you talked a little bit about this Merlin innovation, but in epilepsy surgery in general, obviously we're now using robots to, I'm sure you're doing the same thing at your center, to place our SEEG electrodes, sort of robotic with using the ROSA and other instruments like that. Tell us about the future of robots in neurosurgery in general, but in epilepsy in particular.
Yeah, I think so. The term robot, I think, means a lot of different things to different people. We sort of all, we all think about, I don't know, the Terminator robot or robots in movies that are sort of independently, autonomous devices that are just, if you have a robot in those situations, Star Trek or what have you, it's independently doing the whole surgery. Robots today, as they are in use in surgery and have been in general surgery and other areas, they are essentially ways to stabilize and expand the capabilities of a human operator. And so, for much of what we do right now with robots, it's essentially a stereotactic frame that is dialed in sort of more in a more autonomous way. You punch in the coordinates or you draw a trajectory on a screen, and the robot that you have will guide to that position. I think it's not meaningfully different than what we've done with stereotactic frames for some time. It's just simpler. It's made easier by the efficiency of the machine that you have. Technically, one of the companies making the laser devices now is a robotic device because you remotely push a button and the robot drives it forward. That's a pretty simple robot that just moves along a linear path, but a robot nonetheless. I think as we ask, our machines to do more complicated things, the idea that they are robots, becomes more meaningful when we talk about sort of having, a computer decide what the curvature of these needles are that we are steering through the brain. It essentially requires a device not just to decide the trajectory, but to anticipate and model how different rotations and curvatures are going to create an ablation in 3D space. And so our need for computer and motorized assistance, I think, is going to be greater. I expect in the next decade that many of the things that we do in order to increase our surgical capacity are going to be made robotic in that way. And then the big step, the question of will we cross the chasm where we now come to something that where you essentially you push a button and say, okay, do the surgery, and the robot takes over from there. I think that's a big leap. I don't know that we are going to have unsupervised robotic activity in surgery anytime really soon, but perhaps that's something that can be considered in the next generation.
Dr. Neimat, epilepsy surgery continues to be profoundly underutilized. Where do you think is the weak link in the messaging around epilepsy surgery?
That's a good question. I mean, this is something that I think I and many epilepsy surgeons have sort of beat their head against for several decades that I've been involved in it. I think there is still there is still a substantial conception that surgery is very dangerous. That you do surgery. Most of the people I talk to who are hesitant say, well, I can imagine doing that when it was a last resort, but until then, I'm okay having a couple seizures a month. And so they perhaps don't realize the danger of the natural history of epilepsy. That, I think, is one aspect. I think perhaps they overestimate the danger of surgery. That the risk of serious complication or fatality from modern epilepsy surgery is tiny, is 1% or less. And so I think people have difficulty understanding that. I hope that will be helped by surgeries that are somewhat less invasive and therefore a little bit less frightening to people, because I can certainly understand that hesitation. But in the end, there's really nothing more gratifying than having a patient who perhaps was hesitant at first, but decided to go ahead with surgery, and then finding them a year later that they've been seizure-free, and they wish that they had done it sooner. I hear that from a lot of patients, and it's always very gratifying. Very nice to help these patients when we can.
Dr. Neimat, thank you so much for your time. Appreciate you joining us and shedding some light on your perspectives on epilepsy surgery. And again, on a personal note, great seeing you, and I hope we connect again soon.
It is always a pleasure to see you, and it's a pleasure to talk to you today. Thank you very much. Thank you both for taking the time to speak with me.
Thank you, Dr. Neimat.
Thank you for listening to the Epilepsy Podcast. The video content and audio content is not intended to be a substitute for professional medical advice. The views and opinions represented here are merely the views and opinions of our expert guests. Thank you.